Thank you for dialing in. This is the NCRS Access Pilot Program kickoff meeting. My name's Nev. I work for Next Consultancy, and I'm supporting this as a senior responsible officer in terms of this program of work on behalf of the Primary Care Collaborative. So I'm just going to give everyone a few minutes just to dial in. We're not quite at 1:30 yet anyway. So we'll just wait on a few minutes to let and see how many people we get. Hopefully, we're going to get quite a few here tonight. I've just seen Fiona. Hi, Fiona. Just let everybody in. Yeah, like I said, we'll give everyone a few more minutes. But yeah, thank you to everyone for dialing in, taking your time on an evening. Although it is too cold to be outside anyway, probably there's no snow left, so no one can be out sledging or skiing. So probably better off indoors on this call anyway.
We have got somebody, sorry to interrupt, somebody sent me a video earlier on of skiing in County Durham. One of my relatives in London said, have you seen this? Yeah, Weardale Ski Club. Plenty of snow there.
There was something on the news last night, actually, on the local news about skiing up in the north, it was Northumberland way, but I didn't know County Durham as well. Happy days.
I live in County Durham. We've still got a foot of snow.
Yeah, we've still got snow here, actually. I'm sitting in Durham City just about, and the bits that were left, they've frozen solid. So they're now like sheets of ice. Awful. I think it's my first experience.
I live in Concert.
Since I got. Oh well, you've got it all year round.
Yeah. It's cool.
It snows in June.
Yeah. Oh dear. I just said I don't know where you found this, Nev, but my first experience of an electric car in proper cold weather.
Yeah.
And your charge just goes.
Yeah. I had this conversation with Michael. Yeah, absolutely.
Yeah, I thought it was just my car until now. I felt so much better when I felt out it was everyone.
I've watched every mile on the way home from Stockton. I started off with 47, and when I got home, I was on 17. Well, it's not 30 miles from here.
Yeah.
That's right, Robert. Yeah.
Right. Excellent. Right. So I think looks like we've got 21-ish people, and that obviously includes a few of us as well. But if everyone's okay, we'll make a start. I'll just run through a few things first. Obviously, first thing to point out, we are recording this. There's a few people that did ask to attend but couldn't make it, so we did say we would take a recording. And that's the point when then I have to watch it back, listen to myself talk before then we send it out, which is awful. But que sera. Anyway, so we are recording it just so everyone's aware. This is, like I said, the NCRS Access Pilot Program. This is the kickoff meeting. Anyone that dialed in before, I think it was on the 16th of September, 16th of December, sorry. That was the webinar call that we had, which was introducing what this was. And we had Rob talking through access to the system and how it would all work. We wanted this call because obviously everyone that's on here now, all those people that can watch it back, should have completed the expression of interest, should know something about this. And this is really the next steps. This is us actually getting onto the system, starting to use that as part of the pilot. And the purpose of this call now is to really go through all of those next steps. It is less formal than the last one, hopefully. We have got a few slides just to talk through, but any questions that you have, please either pop your hand up, pop them in the chat, and we have people that I'll go through in a second on the call who will be able to help through some of that as well. So the other thing to say is this is a pilot program. We are all going to learn from this. This has been run previously for pharmacy, community pharmacy, but this is the first in the country, and I've got Rob from NHS England on here from the summary care record team, who has assured us we are the first region, we are the first people to get optometry and dentistry access to this summary care record in this way across the country. So we are trailblazing this for the rest of the country to catch up. So without further ado, I'm just going to ask Rich if we can just bring up the next slide, please. I'll just run through again quickly in terms of the agenda, We're going to go through a quick overview of the program, what it is. Fiona, who is on from the Primary Care Collaborative as well. For those of you who don't know about the collaborative, Fiona's going to kind of introduce where this came from and what the collaborative does. Run through the purpose of this meeting, which I've kind of already alluded to. Part of that is around the next steps, the timeline that we're working towards, the actions that are going to need to be done next in order to get access to this. We've got Zam as well from the Registration Authority team in next as well to talk through, again, in some more detail, how all of that is going to work. And then we're going to finish off with some of those, any questions that people have got that come up at the end, have a further discussion. We've also got an ask back around how we work together to evaluate this as well, working hopefully with patients or getting some of that information back as well. So that's the purpose of how we're going to do this. That's the way we're going to do it. So yeah, so if we just go on to the next slide, please, Rich, just to bring up, so just so everyone's aware, this is the program team, if you like. So most people are on the call now. What we're going to do, rather than spend the entire call introducing everybody, as people who are presenting are going to speak, they'll introduce themselves, who they are, they're kind of the role within the program. There is an ask as well, if we can ask everyone that's dialed in to just pop in the chat your name and which practice you are from, just so then we can collate, obviously, who's on the call, and then we'll be following that up with further emails in terms of access, information regarding email addresses, mobile numbers, which again will come through to later on. Just wanted to give a couple of quick shout outs. I know I've already mentioned Fiona from the collaborative, but Rob from NHS England from the Summary Care Record team. We've got Claire from the Information Governance team as well, here to support with everything that is information governance. And obviously Simon and Steph, who you should all know well from dentistry and optometry. They're our leads for the program as well. Okay, so I'm going to hand over to Fiona to kind of give a brief background, say where all this came from, and then we'll work through the slides from there, if that's okay. That's all right, Fiona?
That's absolutely fine.
Yeah,
thank you.
Thank you.
So I'm Fiona Adamson. I'm the co-chair of the Primary Care Collaborative with my colleague Mooney, who you might have seen on a previous call, who is the clinical co-chair. So firstly, I'm almost Switzerland. So my day job is not a GP, a pharmacist, an optometrist or a dentist. I am the chief exec of the Hartlepool and Stockton Health GP Federation, hence my rather traumatic journey home in -3 from Stockton to Durham. I just wanted to give you a very few words, and for two reasons. One, because there's far more exciting things than to hear from me, and two, because I have a clash with a Parent Teachers Association meeting, which, to be honest, judging by the WhatsApp, is far more challenging and likely to be far less fun than this is going to be. So just about where the collaborative came from, what we do, and what we're hoping to achieve. So if I just take you back a couple of years, or maybe even 3, when ICBs were first being discussed, the idea of a collaborative was born, and I think for 2 reasons, really. I suppose one good and one bad, or slightly more challenging. Initially, the challenge. Now, we are an enormous ICB. We are the biggest geographically in the country, and I think we have a little dispute with Greater Manchester about whether we are the biggest in population terms, but we're over 3 million. That brings advantages, I'm sure, but it actually brings a lot of challenges too, because of the sheer volume of practices that are working there, the sheer volume of patients, the number of relationships that you need to make. And from our point of view, initially in GP land, we felt that there was a real danger that there would be a very quiet voice for general practice and for wider primary care in an ICB of that size, considering that clinical commissioning groups that had been around before were, in theory, GP-led. So a group of us got together. We also thought about what the positives could be of bringing in conversations between wider primary care colleagues. And I think it's fair to say in a lot of places there weren't really great relationships or strong relationships between pharmacy, optometry, dentistry, general practice. There just weren't people who knew each other. And we thought if we could create those links at a North East and North Cumbria level, well, number one, there were bound to be some things that we could learn from one another. We would be stronger together. So I haven't got the vision of the PCC up in front of me, but the idea is that we are better working together. We have a stronger voice. And ultimately, we all agreed that we could do better things for patients if we worked more closely together, and even if we just understood walking a mile in each other's shoes. I ended up chairing the meeting the first time that the four pillars of primary care, if you like, came together, and we said, let's give each other a brief overview. And I have to say, it was pretty much a race to the bottom as to who had it the toughest. And that was a couple of years ago. I don't think things have got any easier. I think I just saw Tom on there, who's one of our dentist colleagues. Tom was in the room. I think the dentists won it by a short head, Tom, but it was a really close run thing. And I think it just showed how challenging the primary care world is. So it's absolutely been one of the most positive things that we've done. We've worked together as a team to set some priorities for 2024-25, trying to bring in the voice of some of our members or practices or consultants, if you like, and then going through a priority exercise, a ranking exercise to decide where we focused our time and our limited funding. And to cut a long story short, access to patient records in the right clinical circumstances for colleagues in optometry and dentistry came out as something that everybody in the room thought was incredibly important, for any number of reasons, but to enable you guys to provide better care, more clinically appropriate and safe care, to save you time in the long run, to stop on occasion GP practices who are notoriously difficult to access and busy, stop them potentially being effectively post boxes in some of these pathways of care. And ultimately, because we felt that the experience for patients would be so much better. So I hope you can see I've come full circle there. So we decided if we work together, we can provide better patient care. And actually, for any number of reasons, we're excited about this, not least because we're so competitive. And if we're the first nationally, that's fine by me. But actually, because this really brings to life the point of a primary care collaborative for me. So I'm going to shut up at that point, and forgive me when I duck out to go and do my less interesting meeting. But I think I'm handing you to Michael, am I?
Brilliant. Thanks, Fiona. And I'll not take it personally when you disappear. So I'm Michael Tate. I work for Next Consultancy. I'm the senior program lead for this, for the Care Records project, but I've also had the pleasure of working with a collaborative for the last kind of 16, 18 months now. So the key purpose of this meeting today, so outline the objectives, and I think Fiona's touched on that already, but ultimately we are here because, we want to deliver connected and improved services for our practices and our patients. And to achieve that via this route, that's about granting access to summary care records for our dentistry and optometry colleagues. So that's the ultimate objective of this. We logistically will talk you through the practical next steps of what we require from you, and equally, what you can require from us and what you can expect from us. So we want to outlay the critical next steps to get us live within this pilot, and that will take us from really the next 4 weeks in the tightest timeline. We'll give you a chance to ask any questions, and again, while outlining that support that we would need from you. And from an expectation perspective, I've put on there about the timelines, but look, step one, you're already here, you're already engaged. This is something that you're interested in, that hopefully you're buying into and excites you like it does us. We need your commitment. We need your best efforts, and together, ultimately, we'll deliver something which can make significant changes, and that's been said a couple of times, be that national first across NENC. But jumping on from where Fiona got us to with the priority setting there, I'll take us slightly back quickly from timeline. So we held the priority setting workshop in May, and there was various bits going on, which led us through to August when we conducted a scoping exercise. That was predominantly with our primary care collaborative representative colleagues from optometry, dentistry, and pharmacy. We also talked to ICB colleagues, but heavily engaged with general practice as well from a governance perspective. What we did in that scoping exercise was we identified potential solutions, we made a case for change, and then ultimately, right the way through that, we came to a recommended solution, which in brought us right here to NCRS. We've taken that, and into November, we've been ambitious. We didn't necessarily know where it was possible to be. We probably got carried away. Never think it's fair to say that we could what could be achieved and what was possible. We kept expecting to be told no along the way, so we continued to push that because we weren't, and then all of a sudden we have got the go ahead. We've got the colleagues that have been introduced on the call from the Claire with IG, Zam from Registration Authority, and Rob from NHS England. We've kind of been working in the background to design this program. We to really, when we came to you, we wanted to be very clear about what we wanted and what we needed. And whilst timelines are the thing which have been kind of probably more fluid, we've been very clear about what we needed to achieve and how we were going to do this properly. So we've designed the program. We've engaged our lead through Stephanie and Simon, and we've got our pilot sites here now, and we've been putting that appropriate governance in place. So that brings us to today. I won't talk about that January block because it's really important what Richard's going to go through for us in the next slides. But jumping ahead, so that once we work through those practical steps, we're into that February phase where we will have access to that live data, and everything will be done, everything will be safe, everything will be proper. But that's really our onboarding phase where we'll be wrapping our support around and saying, look, this is where we are, this is what we can do, because we have a commitment to make this as successful as possible, and we're only going to achieve that by working together as we can. March will see us flip from a pilot perspective to more of an evaluation phase. So we want to really start to capture there. So if we have the kind of the teething phase and onboarding and then that usage in February, we want to move to understanding what the benefits are from a practice and business perspective, from a patient perspective, from what is that experience, and really because ultimately that brings us towards April. And if the evaluation tells us that this is something which is really positive, really well received, it's providing practice, business, and especially fundamentally patient benefit, that gives us the case to then learn, reflect, package this up, and then roll it out beyond April, right across NENC, as wide as we possibly can. So again, it comes back to that. We will ask you for your commitment, your engagement, and positivity where at all possible to make this successful. But that is all from me, and I'll hand over to Rich.
Thanks, Michael. My name's Rich. I'm part of Next Consultancy, working with the Primary Care Collaborative for the past year now, and I'm the project lead for this pilot. As Michael says, I'm kind of going to give a bit more detail into actually practically what are the next steps, what the actions we need you to do. So as you can see there, we've pretty much got there with confirming all the pilot sites that we're going to be running the pilot with. So we're kind of moving into now getting the details from the individuals in those sites to set up their registration process and kind of get them onboarded. Once we've got their details, the registration authority can start to set up their profiles. That will then be passed over to you guys to just complete that process. Then you'll be setting up your MFA so that you can log on securely. And then there's a couple IG documents that we just need to check are in place. And then some training. There's a couple Learning Hub modules and information that you can read around the summary care record access. But yeah, for the next step, if you're going to take anything from this meeting, this is what we really need you to do in the next kind of couple of days. So hopefully by close of play Monday, I'm going to pop a form into the chat of this meeting, and it's just an Excel spreadsheet, and just need to get you to fill in your name. Hopefully, if you've got an NHS email, use that, but if not, just a work email address, a phone number, and then again, just which site you're from. Then send it back to that email address at the bottom there. I'll pop that in the chat as well. And that will allow us to collate all that back on Monday evening, and then get it to the registration authority, who can start setting up your registration process. On the right there, just kind of a summary of like where that kind of fits. So essentially, be creating a care profile, which is just like an NHS professional ID. And then once you've got that profile set up, the roles for this can be applied to your individual profile. So if you're a privacy officer, being assigned that role to that profile, along with access to PDS, your MFA will be linked to that profile, everything like that. I hope that makes sense. As I say, I'll pop the form into the chat now. So if you want to take a look at it and have any questions at the end, I'll answer them then. But I'll hand you over to Zam from the Registration Authority to kind of talk you through in a bit more detail about that.
Thanks, Richard. Good evening, everybody. My name is Zam. I'm a Senior Registration Authority, and I will be involved in getting you guys set up with your relevant user profiles to access the summary care records. We have various stages in terms of the process. Once the information's been submitted for your name, your mobile number, email addresses, that information will be uploaded to our systems. That information will then in turn send out invitation emails to all of you, and then you'll be given the opportunity to upload the relevant documentation. Once the information's been uploaded, I'll be able to get an answer in terms of verification. Once that's been done, I'll be able to create your profile. Now, that's the first part of the RA. The second part is the MFA setup, the multi-factor authentication. Once you've been registered for a profile, I'll be able to get in touch with you directly to arrange a time for a meeting to actually go through the various steps for the MFA. Okay, there's a couple of links on there which will just give you an overview of how everything works. I'm just going to mention a little bit about the privacy officer. Now, the privacy officer under information governance rules, specifically the care record guarantee, organisations have an obligation to ensure its staff access patient information appropriately. Right, the way this is handled with summary care records is by using alert viewer tool. To access a tool, the nominated privacy officer is assigned a nominated role to access and make sure that all the alerts have been carried out in accordance. There's some information on there in terms of privacy officer training, but what I want to mention before I move on, we're actually referring to it as privacy officer, but that has since changed to the summary care record governance person. Right, when you go onto the privacy officer training link, it will actually refer to the SCR governance person. So I didn't want to cause any confusion, but for the moment, we're still referring to it as a privacy officer. Thank you.
Okay, so I think this is back to me. So I'm really conscious there's a whole lot of information that we've just gone through. So what we want to do now, if people have got questions, we might just bring up the slide with the next steps and actions, which are key in terms of the dates that we're aiming for. But if anyone's got any questions, I don't think I've seen anything in the chat yet, which means this has all been either so clear that everyone knows exactly what is going to happen next, exactly what everyone has to do, or everyone's just shocked and like rabbit in the headlights. So the kind of the floor's open, I guess. This is your time now to ask questions. Like I said, we've got Rob from NHS England. We've got Claire from governance, obviously Zam from the RA team. So this is your chance, I guess, if you've got any questions. And can we just bring slide 6 back, just with the expectations and the some of the next steps? Yes, go on, Simon. Start us off. And a quick shout out to Simon. Simon actually wasn't going to make it. He's made changes. You were on holiday, Simon, and you've still managed to dial in. So thank you.
I'm on holiday in my dining room. Sam, yes, can I just ask the NHS Care ID? The previous slide, up to 2 slides ago, it said you required that information, and then the following slide said how to apply for it. Am I correct in thinking that we will apply through you for the unique ID or not?
Which slide were you referring to, Simon? Sorry.
Right, if we go, can we flick?
That process will be handled by the registration authority.
Right.
All we need you guys to do is send us your name, the email address, and the phone number, and then we'll get that to the registration authority, and they'll process it. That's what it means.
Yeah, yeah. But basically, once you provide your NHS a mail account, mobile phone number, your full name, once we've got that information, we'll take it on from there. In terms of getting you registered onto the system, it's a case of making sure you are who you are, with respect, right? So please don't take offense. Making sure that all the relevant ID documentations have been uploaded and making sure that everything's correct, So that's the opportunity of you getting registered. Once you guys are registered, that in turn will then generate your unique UUID number. Okay, once that's been done, then the conversations in terms of who the nominated privacy officer is going to be, who's going to need the SCR, those conversations will probably take place around about that time, if not already provided. Does that make sense, Simon?
It does. And can you also just clarify? I know I understand because I sent you an email, but can we just clarify, Zam, around the fact that the privacy officer can also be someone who's accessing the summary care record?
It can. Yeah. Stars are generally less headcount, small amount of people are working on the stars, so it can be difficult to say one person's going to be the privacy officer, the other 2 people are going to access summary care. It's about common sense approach in terms of, if you've got several people who've got the privacy officer, then you can basically make sure checks are put into place to make sure nobody's logging on to summary care records, which they shouldn't be. It's all about legitimate reason to access the information. And if you've got several people, that's absolutely fine.
Great. Thanks for that. Thanks, Simon. So I know a few hands pop up and then go back down, but I think, is it Deepak first and then it'll be Tony?
Yeah. My question was, yes, there's a privacy officer who will be appointed as part of the whole process. So will the privacy officer need to be there in the practice all the time, and be able to be only person to be able to access the records? Or can you share it with your practice managers who is there all the time, and through her, can we share the records?
So you have 2 roles. You have the summary care record access role, which is in terms of basically logging on and checking the relevant information. Yeah. Then you have a privacy officer. The privacy officer's purpose is basically to make sure that anybody who is accessing any of the summary care record patient information is doing so for the right reasons. The privacy officer receives alerts. They can get it set up on a weekly basis, on a daily basis, depend how your star is going to operate. And basically their role is to make sure whoever accesses a SCR has done so for the right reasons, and there's a legitimate reason why they've accessed it. You can, for the moment, because you guys don't have SCN connections, that will be set up via a reporting mechanism with NHSE.
Sam, can I cut in here? Sorry.
Yeah, of course you can.
Sorry, Deepak, If I'm thinking of your practice, correct me if I'm wrong, but you've got, I think there are 3 dentists, including you in the practice.
That's correct. Yes.
Yes. So one of you, I presume you would be acting as Caldecott guardian within the practice.
That's correct. Yes.
Yeah, you're sort of clinical lead. So it
Yes.
may be most appropriate that you are the privacy officer or the governance officer, and you will receive alerts when people access the summary care record. It would be appropriate that you regularly review those alerts and just seek assurance that the your clinicians, and obviously reflect on your own access, that you're accessing it for the correct reasons, that they are patients of your practice, and that you have justification for viewing those records, not just out of curiosity, but you're updating the medical history. The patient maybe couldn't remember all the medication, or something like that.
Yeah.
Does that make sense?
Yes, it makes sense, Simon. What my question was, Simon, was, say, for example, I'm on a holiday, for a couple of weeks. So at that time, can my practice managers use my ID and access the records? No,
definitely not.
No.
You've got, she has no justification for viewing those patient records. And in fact, in order to get on DPAC, it's multi-factor authentication. She would actually have to keep your mobile phone, which I suspect you wouldn't want to do that. And you'll be alerts to your mobile phone, a code sent to your mobile phone in order to access the summary care record.
Okay, fine.
Yeah,
so, but,
that makes sense.
Yes, but can she be part of the whole process as well? Or is it only one person per the practice?
No.
Yeah.
Yeah, sorry. Yeah, she can, Deepak, she can be set up. You can even forward plan if you know you're going to take leave. You can get that put into place as well. Or if if you are a small store, small practice, you can pretty much have several people set up.
Okay.
Yeah.
Okay.
For all, it's to basically cover eventualities of sickness, absence, leave.
That is all. That is all my thinking was. Thank you.
No problem.
Yeah, just to come in on that as well. I think the original question as well was, do they have to be there all the time? I think the answer to that is no. I don't think they have to be there all of the time. And again, I said this right at the beginning. This is a pilot. We are continuing to learn. We're continuing to ask questions to the likes of Rob, Zam, all of the time like this. And originally, what we were planning on, there would be one person in the practice who would access the records, and one person would be privacy officer. What we've quickly learned is actually it doesn't work like that. If you've got 4 people who want access to the records, and that might be all of your dentists, optometrists, or however that works, then we can have multiple roles. So your privacy officer, because this is all about not marking your own homework, is the way I keep saying it. In the simplest term, is I can't go and access the record and then say, yes, I access the record in reasonable access. So that would be me marking my homework. If I had colleagues who I was working with, I can't, and I think Rob put this in, you can't actually close your own alerts. So there'll be multiple people in the practice. And again, Simon, this comes back to the question you asked me before around the numbers of licenses, because we might find actually we've got more numbers of licenses because we're actually operating with multiple roles, so we could be in that position. So does that answer the question as well?
Yes, I'm pretty happy with that. What you just mentioned. Yeah, thank you.
Fantastic, thank you. Next, I think, is it Tony? Sorry, I can only see half of you. Yes, Tony.
Hi, yes, sorry, well, you partially answered one of the questions, I think. So the first question was, do you need a privacy officer for each practice? We have a 3-practice optometry group. So do we need a privacy for each practice? Well, I'm guessing can you probably need one anyway, just to cover off your own alerts, for example. Is that correct?
Yeah, so I think, is it Rob? I think, did I see you nodding? Do you want to come in on that?
I can answer absolutely fine. So that could be one individual that has privacy officer access for each of your sites or each of your codes, your site codes, or it could be 3, or it could be 6. It could be 1 and a deputy. It can be any number of it. It completely depends on how you want to set that up. We've not had that question yet, no. So
just limit the fuss for you. I think probably myself and the other director probably would be the best option.
That's fine. Yeah.
Just to cover it off with both clinicians. And the second question, really, which I think is a fairly easy ask, was the form you've asked us to complete whenever we get the chance to complete it. requiring the the name, NHS email address, and phone number. Do you want that initial form to contain all of the potential users or people who are going to access the summary care records, and all the clinicians? Because we have about 6 or 7 clinicians across the 3 sites. Do you want all of the details? Not a problem. Just a quick, just so I know when we finish this call what I need to ask my staff to do, really.
Yeah, I'll probably bring in Rich, because Rich is going to be managing a lot of this. I think that to give an answer, Tony, I think the more simple way we can manage this, the better. So if you can provide us within the practice all of everybody's name, email address, and phone number quickly, then yeah, that's absolutely fine. If that's going to take 3 weeks to get everyone, then actually we'll just get it individually, because ultimately we're up against it in terms of time and getting all of this registered, because what we want to do is get people registered as quickly as possible to get online, to use it, to learn from it, to experience it, and ultimately benefit from this. But if that means within the first deadline, I think we set it as by close of play Monday, ideally, to get a list of people back. That means we can get that list over to Zam and the team to get the Care ID created. As soon as we're there, we are literally kickstarting this off. We've set timelines of a week apart. If for example, Rob, you wanted to go quicker, or Tony, sorry, you wanted to go quicker than that, we can accommodate that. We've set timelines that hopefully are achievable, because people have got day jobs and this is an additional ask. But if people want to go quicker and you can provide that in bulk quicker, then that's what we would hope for.
Yeah, no, I think it shouldn't really be an issue. I think, just to get all those 3 things off people, if I get them done within, a day or 2, maybe.
Yeah.
So just when the link isn't up on the chat yet, is it?
Yeah, I was just going to say that the form for some reason won't drop into the chat, so I'll keep working on it, but if not, I'll send it out after this to everyone.
Yeah, that's fine. Yeah, that's fine.
Yeah, and just to kind of follow up on what Neb was saying there, I think first and foremost, if just everyone on this call can get their details in by close of play Monday, we can kind of start off with just that. And then work with yourselves and Simon and Steph to just kind of make sure, because we've only got a certain amount of licenses, so we just need to be double checking that we're actually kind of staying within the number of licenses. So working with, as I say, yourselves and Steph and Simon to just keep the numbers in check, basically.
Yep.
Does that make sense?
Yep. Nice.
Yeah.
Thank you.
Excellent. I think, I don't know, Deepak, if that's an old hand, a legacy hand, or if you've got another question. But I think Ikram, you've got your hand
no,
up.
I don't have.
Okay.
I don't have any questions. Sorry.
Okay, no, that's great. Thank you. Is it Ikram?
Yeah. Hi. Just my main question is, how many licenses are we able to have? Because I've got quite a big practice. We've got about 10 optometrists.
Yeah.
And then like about 50 members of staff. So obviously the privacy officer, we probably need 2 or 3 people to have that, and then licenses.
So as part of the pilot, the funding that we got for this, and it's a small pot of funding, believe me, we've actually acquired 50 licenses. What we originally said, which is my point back to Simon, we allocated 25 just as a fair split. You should have linked in already with Stephanie, because Stephanie's already provided a list of numbers against practices. So our first point of call, once we've got these details, as Rich just said, we'll be cross-referencing that back to the likes of Simon to say, Simon, you said 5 for this practice, but actually, I don't know, say for example, Tony, you've sent us 10. So we'll then cross-reference that back to make sure we're allocating the licenses out appropriately. But we have, for the total pilot, 50 in total. That's what we've actually got. So that's what we're working with. If now, like I said, we're continuing to learn with this, if it means we can give people dual roles, so you can be a privacy officer and a user. We were originally saying if it's 4 per practice, that would be 5, because you've got to add on a privacy officer. We might be able to free up some licenses, but we need to go through this first stage first, and then we could be able to come back and say, actually, if there's another 5 licenses we now have, it might be a case of scramble, who's first gets it, that kind of thing. If we get to that point, hopefully.
I don't think anybody asked me about how many licenses I would want.
Okay.
I think I did mention how many clinicians I had in the practice. So I don't know if they've taken it from that information, but I'll maybe mention when I reply to the form.
I would pick up with Stephanie. I know Stephanie couldn't dial in. She's actually got a clash. We can find out, to be fair. I'm just looking now. You're from Specsavers in Carlisle?
Yeah.
We can actually link back in with you because we have got a number against Carlisle Specsavers anyway. So we can check that and see how many we've got allocated.
Perfect, thanks.
Excellent. Simon? Different Simon, sorry.
Yes, it's different Simon. So I was originally dialed in from the car because I haven't finished work and I've just got home now. I've redialed in from my computer now, but I can't see the form in the chat because I've only got the last question in the chat. Can you put it in the chat again so I can?
So you must have just missed the bit. That's fine, Simon. So Rich just updated. He's having problems actually dropping it in the chat because of the formatting. So we're going to send it back out. So again, if your details are already in, Simon, in the or I can see it in there now, we'll find a way of either, if people have still got access to the chat after this, we'll drop it in. If not, we'll make sure it's sent out to everyone that's on the call.
Yeah, do you want me to?
I'll be sending out the. I was just going to say I'll be sending out the recording and the slide deck anyway to everyone, so I'll send out the form with that, I think.
Perfect.
Okay, so we can fill it in, and the plan was that 2 of us are going to do it from the outside clinic. So we're domiciliary, so we travel all around the northeast and seeing patients. But our head office is down in Swindon, so our privacy office is probably going to be in Swindon. Who does all our stuff down there, so he's probably going to be down there doing it, but he won't be accessing records. He'll just be our privacy officer.
Yeah, so again, what we've just discussed is that we can apply multiple roles. So if your privacy officer isn't in the practice all of the time, we've already had that question and answered that, that's absolutely fine. What you might find is if there are 2 of you, again, to save licenses, so we might not need to use 3. It might be that both of you can be assigned privacy officer and user.
Right.
So we're only using the 2 licenses. There is I don't know if you can still see the chat, but in the chat it was dropped in there by Rob that actually you can't close your own alerts on SCR.
No, you can't.
So you would need somebody else to be able to close yours. So you could obviously work together with your colleague and manage it between yourselves. So it might take that other person out of the equation. It might not, again, depend on how we decide to do that.
Okay, no problem.
All right. Okay. If you've got any more questions, please continue to ask. What we do want to ask of you again, if we can just go to the last slide, please, Rich. As part of this, like I said, we're very much still building this program. We're working on now as a project team how we start to evaluate this. We're trying to keep ahead of the curve in terms of where we get to. As soon as practices, individuals start to go live with this, we want to start to capture the use cases. We can see from the dashboard and work with NHS England in terms of how many times people are accessing per practice, per pillar, etc. So from a quantitative, we can see people are accessing this. That equates to some benefit, etc., etc. However, what we really want to get from this is where has this been useful to you guys and the benefits in practices and business, but also to patients. The ask of you, I guess, a bit of this is, how can we best work with you to do this? We're quite happy to come along and sit in a practice, but it might be if we sit in a practice all day and you don't access it once, that's potentially not the best use of time for anybody. Alternatively, we've got different ideas around questionnaires, things like that. But what we want to ask of you is, and we can continue to work on this, is how would you prefer us to work with you, and how you can play back to us what the benefits have been, and hopefully we'll start to build that as we go through. It might even be, actually, you've got access to this. the first week, the first month, you go, I haven't actually had to use it at all. I haven't used it. That's still useful for us to say, well, have you had problems accessing it? No, it's just I haven't had the need to. Okay, that's absolutely fine. Where you might have somebody who's saying, I've accessed this 5 times a day, and actually there might be one case that we say, by accessing this, I was able to change the patient pathway, the treatment pathway for that patient. How do we then capture that? Because that's the real kind of jewel in the crown of what some of the benefits of this are going to be and how we can roll it out further. So the last sort of few minutes, I don't know if people are happy to speak out or pop something in the chat. How would we prefer to work? Go on, Claire, start us off.
Hiya, I just wondered if the privacy officer, because obviously it won't capture if you're not using it, but could the privacy officer, when they sign off the record, make a note of why the record's been accessed and send it to you, or keep a log or something?
Oh, you're onto something there.
Because they're going to see everything, aren't they? Yeah. They're going to see every time we've accessed it.
They are. Sorry, I've jumped in there, but that is an interesting point. And I haven't got a screenshot to hand, but when you access an SCR, all free text that's added at that screen will be visible to the privacy officer, hence me jumping straight in. There is an optional field which may benefit us, which was actually added many, many moons ago for community pharmacy for this purpose and another one, which is a bit inappropriate for this purpose, but there is a free text field upon you navigating to that SCR that the viewer, clinician, can add a line of text and then click yes and access the record, which would then become part of our digital evaluation. That might work. We can pick that up later on exactly how we do that, but it won't take very long, if that helps.
Yeah, cool.
Excellent. Sounds like you might have cracked it already, Claire. So that might get everyone an early tea.
Can I just suggest that what Claire's, it's very good for the evaluation, but I can see an awful lot of clinicians, if they're acting as privacy officers, saying, my God, that's a hell of a lot of admin for me to do. So just a word of caution.
Absolutely. And that's why we're asking, because what we don't want to do is set something in place where we say, this is what the ask of you is, and then people come back saying, well, I just haven't done it because I haven't got time. So again, as a project team, we're happy to work with you in whatever way is best. But it's, again, it might be you access it 10, 20, 30, 40, 50 times, but there's one time that actually when you accessed it, it really made a difference to that patient's treatment pathway. That if we can evidence that, alongside all of the quantitative stuff around, isn't this fantastic, between optometry and dentistry last month, the summary care record was accessed 1,000 times. That in itself is fantastic. There's value added there. But it's those individual circumstances where it might have really benefited patients, really benefited yourselves, that we need to capture. Because if we take this back to the ICB to say, this needs commissioning further, these are the reasons why you need to do this for optometry and dentistry colleagues, then that's what's really going to make some of the difference, hopefully. Yeah, sorry, go on, Ian.
Just to echo what Simon's just said, that it's probably better from our standpoint if that's not the privacy officer's duty, that's the duty of each individual clinician that's accessing the records. I think you'll get more information, probably higher quality information from the people accessing the records rather than it being passed on to the privacy officer.
Okay.
Can I just come in there now, please?
Yeah, absolutely, Michael.
And I just want to be really clear, reiterate what Nev's saying there. This isn't us saying we want you to do more here. It's capturing patient benefit and patient experience is critical, I believe, to why we are doing this, why we decided to do it and how we go forward. A question could, the response, the solution could well be, we can pull all the audit reports, which doesn't require anyone to do anything additional, but is there a mechanism by which we could engage with patients directly who've experienced as they've come through? Is there anything that way? So it's not, the answer might not be the people in this room now doing the work, but can you give us an idea of how we could engage in another way to gather that information, which just adds a richness to the pilot? Silence.
Answers on a postcard
Stunned.
to that one. I think what okay, we wanted to ask the question now because we're at the point, like I said, at the earliest stage of kickoff that we want to ask this. We'll continue. Go on, Tony.
I was going to say, obviously, I think the day-to-day data, as suggested by Claire, is a great idea, especially with the clinicians who are accessing the record can do that.
Yeah.
And it's not all put on the privacy officer. Or privacy officer.
Okay.
But I think if you want to capture some of the more esoteric stories, you might want to maybe have a check-in webinar at the end of the session, so then we can get some more of the kind of stories from the coal face as such, and that might add more kind of examples for putting the case forward to the next level.
Yeah, no, and that's almost a perfect segue, because that's one of the other things that we've talked about is actually having another call like this. And I don't know if it would be useful just before people are going live, if another call like this would be useful. We can continue to have these, or we can reach out. We'll still be reaching out on an individual level, potentially with questions like, how have you found it so far? How have you found the whole process so far? Because you might say it's actually been terrible. It's been really horrible having to do this. And can we improve that? Or actually, it's been really slick. It's actually been really good. I like the step by step. We've got to learn this as a program as well. It's the first time that this is kind of happening in this field. So we are going to learn. Not everything is going to go absolutely perfect. Fingers crossed it does. But if it doesn't, what do we need to do? Because before we potentially roll this out much further, we need to refine a lot of this and get a lot of this information back. Otherwise, what we'll do is we could potentially come out periodically with questions, set kind of questions around how have you found using it? Have you used it? Have you not used it? Are there any specifics? If you kind of then say, yes, there are some specific areas, we can then potentially have further calls and delve into that detail more. If that's how we're going to do that, we will continue to do that. So yeah, right, that's brilliant. I'm just conscious, so unless anyone's got any more questions, I'm more than happy to give the gift of time back. Oh, Claire, go on then, Claire. Just as I said that.
I know, sorry about that.
Go for it.
I was just wondering, when we're going to send the list in of our optometrists, if there is, if we're going to be looking at the number of licenses, would it be helpful to prioritise who on that list we would like to give a licence to first? Because just thinking, because obviously we've got, Tony and I, we've got full-time members of staff, but we've also got people who work less hours, and obviously we want to get the most bang for buck. So shall we rate, like, prioritise them?
So I think, as Rich said, I think the first step is everyone on this call now, send your details through. We will get you on the list first, and we can work that priority list through, because the ask of everyone on this call now was to be kind of the lead. So you will be leading the way. You'll probably be the first guinea pigs, the leads, guinea pigs, however you want to call yourselves, that we'll be looking to get through first. What we'll do is work with Stephanie, work with Simon as the pillar leads within their respective fields to kind of then go through the list. And like I said earlier, we've got a spreadsheet at the moment with practice names and aligned numbers. And if we see that there's originally 5, we receive 7, we'll go back to Stephanie and yourselves as a practice and say, okay, you've asked for 7, but we've only got 5 licenses that you can have. That would then be an individual conversation, I think, Claire, to say who would come in, who would go in and who would go out. Likewise, like I said earlier and said to Simon, it might be actually we have some licenses spare at the end, and we've got 50, let's use 50 if we can, and not leave people out. So that would be the plan. Again, we'd work off the original list that Stephanie and Simon sent through just before Christmas, and that would be our starting point. All right. Any more for any more? Otherwise, I'm going to say we get, what's that, 7 minutes or so back to, no, yeah. So kind. We're all about giving. But before I do let everyone go, I do want to say a massive thanks to you all for dialing in. I know it's a Thursday night, but we are so passionate about this. I hope that's come across. We really, really want this to succeed. So thank you again for dialing in, for taking the time. This will be recorded. We'll send all the slides out, as Rich said. We'll send that form out. Any questions, please use the email that is in the chat now. It's the NCRS Access email, because if you email myself, Michael or Rich, we might not get back to you as quick, but there'll be someone manning that mailbox all of the time. So thanks again. I've just used up another minute, but great to work with you all. And thank you very much again, and have a good evening.